So let's have Dr. Attizzani from University Hospital in Cleveland join us, please. He's going to show a live case of a self-expanding valve and cusp overlap view.
Can you hear us? Hello, can you hear us?
Hey, Gil, can you hear us?
Yes, loud and clear. Hi, everybody. I can hear, I know that Sushil is there. Who else is there? Could you please introduce yourselves to us before I introduce our team?
Hey, okay, this is Ramesh Dagubati. I'm with Dr. Ashish Prasad, Dr. Sushil Kodali, Dr. Pramod, and Dr. Gurdeep. Good.
Excellent. All of the great friends from India. It's very nice to be here with our team here. Chris Baeza, my partner, cardiac surgeon. We have Hitesh, our fellow. And we have also, you know, Kat, Kyle, the fantastic team from Medtronic here, as well as our team from the video. So we're going to, Hitesh, our fellow, is going to start presenting the case. Please go ahead, Hitesh.
Good morning from here. Good evening in India. We're going to talk about a live case of transcatheter aortic valve replacement using Evolute FX. Patient that we have is an 80-year-old female with past medical history of hypertension, hyperlipidemia, presented initially with progressive heart failure symptoms, with difficulty breathing and with daily activities of life, and was referred to us by her primary cardiologist for aortic valve stenosis evaluation and possible intervention on that. So, you know, for her surgical risk STS score, the score is mortality score is 2.11, and the score of the risk of reoperation is 3.66, and the risk of renal failure is 0.97. She is NYHA class 2. Her frailty score is 0/5. This is her presenting EKG, normal sinus narrow complex. The pre-procedure transthoracic echo showed LVEF of 55% with the mean gradient of velocity of more than 4 and mean gradient of 40 millimeters of mercury. And the valve area came out to be 0.8. She had also had mild aortic insufficiency, pressure half time of about 600. The pre-workup coronary angiogram had basically non-obstructive disease. And so basically, we evaluated her further for TAVR and, you know, aortic valve replacement, and we got a TAVR CT.
I want you to interrupt you 1 second. There are several aspects to consider here. I was listening to the talk of she was talking about the bicuspid, and this is that, and I know the prevalence of bicuspid valves in India. Obviously, this is actually a bicuspid case. You're going to see a fusion of the right and the left, and there are some interesting features. Number one, I want you to pay attention to the angulation of the aorta, which is above 70 degrees. It's a very horizontal aorta. Keep going there, Hitesh, please, with the measurements.
So the annular measurements, the perimeter is 72.7. The area comes out to be 399, and the left coronary is 11.2. The right coronary is 15.2. The angulation, as Dr. Attizzani mentioned, is 71 degrees. The leaflets, the sinus is like 34, and 33.4, and the STJ junction is 37.5. Going forward, the left upper is basically showing the leaflet calcifications. The same thing is the leaflet calcification on the left lower slide.
Then I interrupt you one more time. So another important aspect to consider here, as you guys know very well in India, right, it's important to consider the phenotype of the bicuspid valve, right? There are bicuspids and bicuspids, right? There's this classic paper from our former fellow Suhanyu showing that those bicuspids with very heavy calcium, nasty distribution of calcium, those are the ones that they carry worse outcomes. In this case, there is a fusion between the right and left. However, the raphe is not like very heavily calcified. There is some calcium there. So this would be like a benign phenotype for a bicuspid valve. And those are the measurements that we have there. So I'd like to open the discussion with the panel. I'd like to hear your opinion in terms of, number one, of course, we're going to do an Evolute valve, but I would like to hear from Sushil. Do you think that SAPIEN valve would be okay here? Would you be comfortable with that? And then after that, I'd like to ask the rest of the panel if you would use a 26 versus a 29. We are in the upper end of the 26 here, big sinus, STJ. I'd like to hear your opinion on it.
Sure, I can start. I mean, I think this is one of the, I didn't catch the patient's BSA 80 years old and big patient
BSA is
or?
1.73.
Okay, not big. So, I would feel, especially in a horizontal aorta, I think the tip deflecting catheter, I think Sapien has some nice features. And so this type of bicuspid, I'd feel very comfortable. It would be in looking at the annular dimensions, probably seal at the annulus, but it would be a 23 Sapien Resilia, in my opinion. In terms of the sizing, I'll let the others comment on the Evolute 26, 29, and I can weigh in at the end as well.
Yeah, so I think obviously the FX changes the game in terms of the 70-degree angle and outside the IFU. We had some great cases shown here where they snared to assist in the deployment of the Evolute Classic and the Evolute R. But I think taking that spline out, we have had some great cases with steep angles and not an issue, and it delivers amazing. So I think your self-expanding strategy is going to work with the current FX. As far as the sizing, I mean, I think you could go either or. If the only concern with the 29 would be pinwheeling, but I don't think that's going to be an issue given if you adequately pre-dilate and the lack of significant calcification on the leaflet on the left side. And the sinuses seem to be not very asymmetric. They all seem to be roughly the same size. So I think you could, dealer's choice.
Excellent. Thank you for your comments. And I agree with Sushil in terms of it could be either one. And it's as I mentioned, benign phenotype of bicuspid. I want you to pay attention. Go to the next slide. I want you to also pay attention to the 3D image. I don't know if it's clear for you guys, but in terms of the axis, you can see that there's a lot of tortuosity also on the axis, which, in the prior generation for Evolute Pro Plus, that might store some tension in the catheter, which with Evolute effects, that happens less often. So next slide, please.
But sorry, you could avoid that, but you don't have to go inline for every Evolute. You could have put in an 18 dry seal and all of calcification goes away. So, but I agree with the FX, the handling in the tortuous iliacs is also much better.
Yeah, we're going to go inline though. Yeah, you're right. And indeed, she could take an 18. If we need to put an 18, we know that the vessel size is okay. But we're going to go with the inline sheet. That's our routine. And I think we have had excellent experience with Evolute FX. And I'm sure that the valve is going to go well there. I don't anticipate any trouble. We're going to use a extra small, extra support Safari, which has a very stiff, it's similar to a Lunderquist, but with the same shape of the Safari wire. Go to the next slide, please.
But if because in India, FX availability is an issue. So if we are performing the same case in India, would your choice still be a self-expanding valve, or you'll?
I would do what Sushil suggested.
Yeah, I mean, I think you can do self-expanding. I guess the question is, if you're doing this case now, you don't have the extra support Safari. Guy, would you use if you didn't have the extra support Safari, would you use a Lunderquist in a case like this?
Absolutely. I think we would. Yeah, we would use a double curve landed. Yeah.
Yeah, for Indian colleagues, this is Ramesh Guy. I just want to say one thing. Don't just do one of this, one of that, and one accurate. And, so I want us to make sure that at least in our practice, we never touched another valve until we became proficient in one valve. And then we switched. Now we use about 60% or so Evolute and 40% Sapien. But when we started, I was 100% Sapien. Obviously, there was no Medtronic valve at that time.
No,
yeah, I could not agree more with you. That's a very important point indeed. Let's keep going.
Let's go ahead. Yep.
Let's go ahead.
So, with the plan, our plan is right femoral primary, which we already have the access. We're gonna go with Evolute 26 FX and pre-deal with 20 mm true dill balloon. So
we decided obviously to pre-dilate since it's bicuspid. I was listening to the talk, Sushil's talk and the comments. We always pre-dilate obviously for bicuspid valves, and we are gonna use a true flow balloon. We normally use the true dilatation balloons. We're gonna use a true flow just because honestly we don't have a 20 millimeter true dilatation. That's all. That's the only reason why. All right. in addition, just to finalize, I'd like to show you go to the next slide, please. Yes, next. So I'd like to show you this slide because we're talking about EOA, and Sushil very importantly asked about the BSA of the patient, right? With a 26 Evolut valve, we can deliver a larger EOA compared with a 23 Sapien valve, right? You can see there on the graph that we're showing there. Whether or not that's going to have a significant impact, right, on long-term outcomes in this situation, of course, it's unknown, right? But that's, I think, an important point to pay attention to, so that the EOA of the 26 is going to be larger than the EOA of the Sapien 23. Okay, we're going to move forward here. So we already have, basically, so you understand what we have here. We have a 14 French sheet on the right femoral arch. It's a centron sheet. We are already through the valve. And we're going to basically now put our Safari wire. We already checked the valve. It's all good to go. And we're going to pre-dilate. And in the end of the case, after we're done, I'm going to cannulate the coronaries, showing the commissure alignment and how long it takes for us to go through the cage to cannulate the coronaries. All right, so we're going to go with our Safari. As I mentioned, the Safari, this wire has the same stiffness of the Landy, and it is the same shape of the Safari extra small.
There was some discussion earlier. Are you pacing off the wire, or are you going to have a separate pacer?
Yeah, that's a great question, Sushil. We pace with a pacer, a transvenous pacer in the neck. Why do we do that consistently? Why do we don't use the wire, right? We don't, because the wire in the very end of the procedure, I like to pull the wire all the way inside the nose cone and pace the patient for the final deployment of the valve. So that's the reason why we do not pace over the wire. In addition, we only use the balloon tip pacers. They're very safe, and if we need to keep the wire in for whatever reason, right, then we don't have to stick the neck. So we usually pace with the transvenous pacer in the jugular vein. We don't go femoral, always jugular. All right. So Chris is putting the Safari there. Looks very good, sitting nicely in the apex.
Okay, I got the wire.
All right.
Is your pigtail in the femoral, or I mean, are you going radial with your pigtail? I see.
No, we don't go radial. It's interesting because we have our optimal practices course here, and I always tell when people come here you can challenge me about any step of the procedure. I will justify why I do things and why I don't do some other things. With the reason why we go transfemoral always with the pigtail, number one, because again, the vascular complication rates of going transfemoral for us is extremely low with the secondary axis. Number two, if I need to use a buddy wire, Lunderquist, for whatever reason, if I am going radial, I'm going to lose that opportunity. Another reason is because our patient's awake. So she's sedated, mildly sedated. If I talk to her, she's going to respond to me. And if we go radial and we start having spasm on the radial with the patient awake, right? And we are across the valve, then it becomes a stressful moment without need. So, and here, in addition, I didn't mention that, but because it's very tortuous, I put a long braided sheet on the left, so we don't fight the tortuosity when we're ready to move the pigtail. That's another important point, because if you need to reposition the pigtail and have to fight with the tortuosity below, it becomes an unnecessary nightmare. So we always plan appropriately to make it happen smoothly while we're here. So we're going with the true flow balloon.
Total projection.
You push.
Yes. Hold the wire.
All right, hold the wire, Hitesh, don't let it move. All right, we're going to pre-dilate now. I have wire now.
You typically size your pre-dilatation balloon to the min diameter of the annulus?
So when we use the true dilatation, we go the minimum diameter normally. It is important to highlight that we never use big balloons to pre-dilate. Some people use, we rarely use balloons bigger than 22 to pre-dil. Very rarely. And the reason being is because pre-dilatation is just to prepare the valve. We pre-dilate more often than general numbers in the US. The general number in the US is around 40%. We pre-dilate around 70%. because pre-dilating reduces the chance of post-dilatation, right? And reduces, obviously, if we implant the valve to aortic, you need to post-dilate, it may become an issue, right? So we pre-dilate very often, and we only use small balloons. We never go beyond 22 because we just need to prepare the valve. In this case, it's a 20 balloon, and we use the minimum diameter of the LVOT. She has no LVOT calcium, and we use the minimum diameter of the LVOT. Flora?
There were some EKG changes.
Yeah. So Chris is pointing out here that there is some a little EKG change with the wire and with the balloon.
Okay.
A little more. Okay, who's gonna pace?
Okay.
All right, ready? Pacemaker on and 180. Pacer off. So another comment here that I have is that some people have concern of pre-dilating patients who have poor LV function. And that's the reason why we like to use the true dilatation balloon, because it goes up and down in 3 seconds, right? So even folks who have poor LV function, they tolerate very well the pre-dilatation. And believe me, pre-dilatation is better, and they tolerate much better than if you need to do multiple recaptures of the valve. In this case, obviously, she has normal LV function, but in patients who have poor, be careful the wire here. Right, coming out with the balloon. What was the last ACT, guys, again?
304, 17 minutes.
Thank you, sir. Appreciate it. All right. Push. Yep. All right. Take it out. Take it out. All right. So ready to go in with the valve now. Predilation was okay. As you could see, 3 seconds of pacing. This is a true flow balloon. Huh? Some people do not, pace the patient to use the true flow because it has a hole in the center. We like to pace. We usually pace same way. We don't do without pacing. It's very safe, and her LV is normal. 3 seconds doesn't really impact anything. All right.
Bill, just to keep you on time, you have about 15 minutes.
Yeah.
So I just want you to focus on the cusp overlap technique so that can be just so that the audience gets the opportunity to see that.
Absolutely. So one thing that is important, thank you for that comment, is that Chris, you have more? Let me I'm gonna take the inline sheet out, the 14 French sheet out. Sorry, you're gonna feel pressure now. You're gonna feel pressure now, darling. Nitesh, help me, man.
We talk of commissural alignment a lot. Does it translate to better hemodynamics in bicuspids?
We don't know.
Yeah. All right. So here, importantly,
We don't.
we're gonna keep the flush port, Flora. Flush port at 3 o'clock. In our paper published on circulation intervention, when we keep the flush port at 3 o'clock, 96% of the patients that we went with evolute effects, they had commissural alignment. Look at how smooth it was to go through the tortuosity. So very smooth. Chris had no resistance, right, Chris?
No resistance.
So no resistance, went very, very smoothly.
So are you going to go LAO to look at the hat marker?
Yes,
Or
we're gonna go
have
to
you stopped
LAO
with-
now.
Okay.
Just before we cross the arch, I want to make one comment here in terms of the cusp overlap. Because this is a very horizontal aorta, right? The cusp overlap projection here is very steep. So it's going to be close to impossible to reach that. So we're going to do a near cusp overlap for her because of that. Because it's going to be really hard to achieve the full cusp overlap view here. It would be like a 54 of Caldo or something. 53, actually, yes. So we're going to go LAO to cross the arch. And as I said, and the current study we're doing, the coronary cannulation one, 100% of the patients, 50 consecutive patients, we did 70 already. They all had look at the valve crossing the arch here. The effects goes very smoothly, huh? Went very, very smoothly.
No projection.
Look at the hat marker, guys. I want you to pay attention. I'm gonna mag one up. You see in LAO, the hat marker in the outer curvature of the aorta. Can you see that there?
Yeah, we can see it.
Okay, excellent. So we have the hat marker there. So far we're happy. So Chris is repositioning the pigtail that is tangled. And again, we're gonna, after we do, I'm gonna just reduce. Can we bring a little bit more lights in the room, please? I need a little halfway through. It's too dark.
Okay.
Puff, contrast, Hitesh. Yes. Push a little more.
Yeah, yeah.
You're close. Just push 1 millimeter. Puff.
I think that's good.
All right, good.
That's good.
All right. So as you can see, very horizontal aorta. You notice that we didn't take any pictures so far, just a puff, but no pictures whatsoever. Now I'm gonna go to a near. I need a little more lights in the room, please. Near cusp overlap view. So it's gonna be LAO 10, caudal 37. It's LAO 10, right? I mean caudal 37.
Yeah.
Bring me full lights in the room. Full lights. This is not happening. All right. There we go.
Move the screen a little south, please.
All right, there we go. That's our cusp overlap, near cusp overlap view. One second. All right, I have the R.
Okay, I'm going in.
Yeah. All right, stop there.
Okay.
Puff. Puff, Hitesh. All right.
Don't make it look so simple, Guy. No.
We're we're trying to make it look very simple because it is actually. Puff. All right, you see the pigtail is playing a little bit with us. You're gonna try to reposition that there. Puff. There you go. Perfect. All right, guys. So you see that. So Chris, so normally with the evolute effects, we start in the bottom of the pigtail with the mark. We don't go halfway through the pigtail. However, Chris knows already that we are gonna start just a little bit deeper here. And why are we gonna do that? Because it's a very horizontal aorta. And we do not want to miss the left, right? This is important. If we start too shallow on the non, we may miss the left, right? Stay still there, darling, please. We're putting the valve right now, okay? Stay very still. So you see, we're starting to come out.
Okay.
Do you usually pace at this point?
Yeah, not at this point. We're gonna pace when we start to flower, we're gonna start pacing. Not yet. Puff.
Okay.
Puff. Good.
Yeah.
That's so the golden markers that you see in the bottom of the valve are located at 3 millimeters. Okay. So we want to be in the non, like around 5-ish, because we don't want to miss the left, as I mentioned. Puff. Good. Coming slow. At this point, we're coming very slow. Very slow. Rotating the catheter very slow. There's no rush. No rush. Let the nitinol come, the tension from the catheter come off gently, right? No rush. We're going slow.
Are you using, do you use the wire at all? Because you're a little bit more on the inner curve here. Do you try to get a little bit more sense?
Yeah, that's a good question, Sushil. So when we are in cusp overlap, sometimes it's harder to see that position of the valve seating compared with an LAO position, but I'm happy with this position. I'm happy with this right now. I'm not gonna push too much the wire. With the FX, I would probably, if I were using an Evolute Pro Plus, Puff. Pacemaker on and 140, please. Now we're gonna start pacing to keep us systolic like around the hundreds. Right to Puff there, Hitesh. Puff. $150. Puff.
You still
160.
haven't. You still haven't made contact on the other side. So now, yeah.
Is it push? No, I did not.
All right, pacemaker off. I do a CNET. Inject, inject. The valve dove a little bit, as you can see, right?
Yep.
So what we're gonna do now? What do we have to do?
I mean, it came very central as it dove, though, right?
But yeah, it
Yeah.
dove
So-
in. So, I mean, I would like
Which is
to.
not
I would take the parallax out of the valve and see.
which is not surprising, right? Which is not surprising because we have that calcium in the non-coronary cusp, right? The valve slid down basically. It's not surprising. So the valve is definitely deeper. Honestly, in this position, even if we take the parallax, I think we're gonna be too deep.
I agree.
You agree with me?
I think you should recapture, yeah.
I think so too. I think we're gonna recapture. So we're gonna do a partial recapture. Okay, partial recapture. Try to bring the valve up in a partial. So for a partial recapture, don't let me lose the wire. I have to hold the wire now. So for a partial recapture, we're gonna pace the patient, right? To same story, bring the blood pressure down. We're gonna try to bring up a little bit the valve and then redeploy. Okay. Have to be ready to inject as well.
Okay.
1 second.
In such scenarios, once you have
All right. Pacemaker
the
on and
horizontal aorta,
160.
the tension on the delivery system actually.
Don't let me lose that. Pay attention here. Use the right hand.
Because if it is too pulled up, then it might not align well and it might fall short. If it is too pushed in, then
Okay.
it suddenly jumps
Like
in.
it? Yeah.
Pacemaker 120. Cine. Inject.
Better.
All right. I think we're happier now.
Yeah.
Let's see here in LAO. Pacemaker off. Fluoro. All right, we're gonna go now in an LAO position here.
Or 5 at none.
All right, ready? Cine. Inject. Happy or frustrated?
I mean, you're on the non about 5 millimeters. I think it'll settle down. It'll go up on the left side. I am okay with this.
Sushil.
I mean, ideally, you'd get a little bit higher, but it's a judgment call. Because you're going to be fighting yourself with this horizontal aorta a little bit. And as you said earlier, as you release with the way the catheter here is in the LAO, it should come up on the left and maybe drop a little bit on the non. I can't see from the screen here. It looks like the parallax is out. Is that correct?
It's totally out. There's no parallax whatsoever in this picture.
So it looks to be about 6 because you see those dots there, right? Was that what you'd say?
I think
6,
for this
7?
position, you can see,
On
I
the
would
left.
definitely feel the capture in this projection there. Yeah.
Okay, so Sushil, so what was your final call again?
I would try to reposition one more time, but you don't, doesn't look like you don't have leak, you have a good seal. I don't know what the conduction is right now. There's a lot of ectopy. I don't remember the presentation. Was the membranous septum short or long?
We don't routinely measure the membranous septum.
Okay.
We don't.
So the conduction looks, what does it look like? I can't see here.
The conduction is the same as it was when we crossed with the wire. There's no, just having PVCs, as you said, but the conduction looks the same as we had when we crossed with the wire. So I think you made a very good point. The fact that there's no leak, right? That's a very good point. And in fact, the LVOT is smaller. I'm talking to Chris here. We're gonna recapture one more time. Okay, we're gonna recapture, try to bring up just a little bit more. Okay. So, but we're gonna recapture in this projection. We're not gonna go back to cusp overlap. We're gonna stay in this projection.
I was just gonna say that because that's generally what we do as well. You've optimized on the other projection. Now you're trying to see here and recapture.
So your focus is the left side.
Yeah.
Don't let me lose wire. All right, pacemaker on at 160.
No, I still would focus on where the pigtail is because you cannot really understand where.
Yeah. I am. Okay.
Pacemaker at 140.
Yeah, this is about, I think,
Cine,
2 millimeters.
inject. All right, happiness or frustration?
That's good.
I'm happy in the LAO. Can you go to the RAO and show?
Sure. Going back here, we're still pacing the patient, as you can see, because the reason why we're still pacing, if you're asking yourselves why, it's not because I forgot fluoro. Right, seen it? Inject. That's our cusp overlap. Happy?
Yeah, we like
Yeah.
it.
Hang on, can you,
Yeah.
we lost
all
the
like
video
it.
for a second. Can we-
You look like you're about 2 millimeters or 3 millimeters deep, right?
Yeah, I think we're good here. I'm gonna pull so for final deployment, and I'm gonna discuss final deployment. You see, wire goes all the way in the nose cone, all the way in the nose cone with the wire. Pacemaker on at 160. So Chris is doing a gentle forward tension in the catheter. The wire came back all the way in the nose cone to take the tension off of it, right? And I'm going very, very slowly. And we're pacing to keep the systolic like around 100, which we have. I don't know if you can see the hemodynamics on the screen.
We sure can.
That's how we like to deploy these valves. We always do a final pacing to keep the systolic around 100. I'm going very slow, as you can see. At this point, also, I see that some people tend to wait for 5 or 10 minutes with the valve connected to the catheter. I'm going to say this. It makes no sense to do that. What makes sense, however, is to do a very, very slow deployment like we're doing, because you come, remember, there's a lot of tortuosity here, and there is tension in the system. See, one of the hooks is out, we're still connected to the catheter. I'm coming slow to finalize the disconnection, which happened right now. We don't keep wiring the ventricle, pacemaker at 120. And we're gonna go dial down the pacemaker progressively. Good. All right, excellent. Pacemaker off.
How horizontal the aorta is. Look at the.
Yeah, exactly. Chris is making a very good point here, guys. Look at how horizontal the aorta is. Can you see there?
Yeah, no, it's a very nice, but you saw how you kept it with the wire back, tension release. It stayed on that non-side. The left came up a little bit as it followed the aorta, because it's going to, because of the crown portion, it has to follow the track of the aorta. So at whatever point, the valve is going to rotate. And so most often it does come up on the left.
Yeah. So I think I was gonna make a comment here. When we were at 80%, you notice that I kept pacing rather than turning the pacemaker off. Why? Because her perimeter is around 72, almost 73. So she's in the upper end of the 26 valve. And at 80%, I don't like to stop fully the pacing at that point, because sometimes it ejects the valve. Remember, the valve is still at 80%, and we are not, the oversizing is not as much. So in this situation, we keep pacing to keep the systolic, around, as I mentioned to you guys, around like hundreds. That's why I kept pacing. And then in the end, as I mentioned, there's no point to keep the valve like connected, wait 5 minutes. No, if we decide we're going to deploy, then deploy immediately, right? And then, of course, the steps, 4 steps, pulling wire back all the way inside the nose cone, minimum forward tension, very slow and pacing. 4 steps for deployment that, as you could see, the valve did not move. The valve canted, which is normal, right? Whenever there is the interaction of the valve with the native annulus of the patient, there's going to be canting. That's normal and expected. But as you could see, the valve was in a very, very stable position. There was no movement, aortic or ventricular, in the final deployment. So now, Steve, our echo sonographer, is doing our TTE. I think you guys talked about the echo, transesophageal echo earlier today, as well as general anesthesia. We do all of our cases since 2014, all of them in local anesthesia with no transesophageal echo guidance, and we feel very comfortable with that. How are you looking there, Steve? So no PVL, no AI. Gradients look like it's gonna be okay. The valve looks well expanded, as you can see by fluoroscopy. The expansion looks very nice.
In both the RAO and the LAO, it looks expanded. So I think it's a good result. We're going to have to leave you in a few minutes.
Dr. Frank, you have a comment?
Yes, I have just a question to you. What I saw, you didn't perform X-ray control of your valve. So we do this in our cath lab routine. So first of all, we make angio from the system, and if everything looks nice, then we go forward. Did you perform this?
You do what? I could not hear you well. You do what? Angio what?
We just make angio from the prosthesis, to see how it looks. It's well crimped, etc.
You mean a final aortogram? That's what you're talking about?
No, before implantation.
No, I think they did do that probably off screen. He was saying after the valve is crimped on the catheter, do you X-ray to ensure that it's not a misload?
Yeah.
Oh, we did that. We did that. Yes, we did that. We just did it offline. Yeah, but of course we do it all the time We did it obviously prior to the pre-dilatation, but we did it. And we just didn't show you guys because we didn't have enough time to do so.
Thank you.
Yeah, of course, absolutely. So as you can see here, just to finalize the comments, if we have to go, I was going to show you guys the cannulation of the coronary, but if we won't have time. Basically now, as you can see, we have, single digit. What was the mean gradient, Steve?
4.
So mean gradient of 5, no paravalvular leak. Next step for us, we're going to cross the valve, get our hemodynamics post. So we got hemodynamics pre, the LVDP was 15. We're going to cross the valve now, get hemos. If the hemos are concordant with the TTE, meaning either the same LVDP or lower, concordant with the no paravalvular leak, we're done. We don't take aortogram. There's no need to take an aortogram here. That adds no value to the procedure unless there is a discrepancy between hemodynamics and the echo. And then, as I mentioned, we're going to cannulate the coronaries now, as we're doing for every case. I want you to see, just to finalize here, this picture in RAO. And you can see the two golden markers there on one side and the other one on the other side. That's an indication of commissure alignment. It's very easy to see that on this device. So we remember we had the head marker in the outer curvature. Now we have the two golden markers showing that we do have commissure alignment. And final message here: every time we need to recap, the recapturing device, feature is excellent. Every time we're going to recapture the valve when the valve is deep, just like it was here, for multiple reasons, obviously, tortuosity, tension, horizontal, bicuspid, right? Try to always pace. It's important to pace so the valve does not get ejected to the aorta. And then, the partial recapture happens much more smoothly than it would. Otherwise, have to full recapture and restart from scratch. Any other comments from the panel? Any other questions?
No, those are really key highlights. I mean, we do the same. We pace at 180 when we recapture because otherwise it ejects the valve, and things like that are small tricks that I think minimize some of the stroke and other risk factors. I think this was a great example. If you want, maybe we can come back for a couple of minutes to show the cannulation after we do the next case if you want. If not, we're okay. And so this was a great example of treating a bicuspid. And I think that, looking at valve choice, this worked really well. And I think we've seen before that different devices, as long as you're comfortable, you have great skill set and nice example of how to handle a horizontal aorta with an Evolut FX. So this is a great example of a case. Thank you so much. I think Srinivas just wants to say a few comments here.
No, I just wanted to thank for all your enthusiasm, interest, and proactiveness to help us. When we asked him last time, immediately agreed. Thank you, Dr. Attizzani, and excellent demonstration of self-expanding valve in a horizontal aorta. Many people think you can't do that, but you did it excellently with proper good explanations, and SFX markers helped that to do well. I just wanted to, and all the colleagues across in India, I just wanted to thank you again for the excellent demonstration. Thank you.
Thank you very much for the opportunity. Thank you very much. I really appreciate that. Thank you. You guys have a great day there and have a great Congress. Thank you.
Thanks again.
Bye. See you.
Bye.